us. So without wasting any time, we will come to the point that this is the first time we are having the CMEs case in the CME. We are having the case presentation with two of our students, one from the Patna All India Institute of Medical Science, Dr. Survi, the other from RIMS Ranchi, Dr. Srishti, will in two cases, two very interesting cases, which are selected by our scientific committee, and they will present. They will be having 30 minutes. In the first 10 minutes, they will present the case, and later on they will discuss, and the teacher will guide also in between how to present. If they are having, and they wanted to say something, they will guide them. So we are having 4 experts, but before that, I would like to invite our chief guest of the day, Dr. Arvindo Ray. He is the past GC member, East Zone. He is with us. Dr. Arvindo Ray, sir. Are you there, sir? Hello? Hello? Hello, Arvindo Ray, sir. Can anyone locate Dr. Arvindo Ray? And our guest of honor of the day, he may join in a minute. I will give him the call. Our guest of honor is Dr. BK Prasad. He is our past president. And Dr. BK Prasad, sir, are you there, sir?
Yes, I am here.
Yes, sir. Very happy to have you as guest of honor of the day, as this is the first CME of the second series. In the first series, we have completed 13 CME in a row. In November and December, December and January, when the COVID was at peak, that 2 months we had the break. Otherwise we are continuing the state CME every month. So 13 CME has been done in the past, and in this second series, we are starting with our much awaited case presentation. So I would like to introduce our sir, Dr. BK Prasad, sir. I request you to please welcome our chief, the experts, Dr. Indrani Madam, Dr. Sonia Madam, and Dr. PR Mahanti and Dr. Ashok Kumar. They are our expert examiner in today. So I would like you to please officially welcome them.
Naturally, it is my pleasure to invite and welcome Dr. Indrani Mukherjee from Mumbai and Dr. PR Mohanty from Tata Main Hospital, Jamshedpur, Dr. Sonia Vadhavan from Maulana Azad, and Dr. Ashok Kumar, very close, my dear friends from Narendra Medical College, Patna. I welcome you all, sir, and please take care that our students get improved by your proper direction and they get experienced by your questionnaire and supportive answer if they required. Thank you, sir. Thank you very much.
Thank you very much, sir, for your kind words. I request our president, Dr. DK Singh, sir, to officially welcome all both the chief guest and the guest of honor. Dr. DK Singh, sir.
Good evening. Good evening, everybody. And on behalf of the Bihar Jharkhand ISA, I am audible. Sharad?
Yes, sir.
Yes, you are audible, sir.
Okay.
Yes, you are audible.
On behalf of the Bihar Jharkhand ISA, I welcome Dr. Indrani Hemant Kumar Madam, Dr. Mahanti sir, Dr. BK Prasad, our chief guest of honor, and chief guest, Dr. Arvindo Ray. I welcome all of you on the dais of our Bihar Jharkhand ISA platform. Thank you. Sharad, you may start now the proceedings.
Yes, sir. So first case, I also want to read the CV of 2 of our external and 2 internal I have with us. First case is by Dr. Sonia and Dr. Pratap Mohanty. So I would like to read the CV which I got from the examiner. Dr. Sonia Vadhavan Madam is Director Professor at Maulana Azad Medical College, and her area of interest is airway and obstetric anesthesia.
Sharad.
Special hello, yes.
Sharad, first examination Indrani Hemant Kumar, not Sonia.
First case is just sorry. Hello.
It's all right.
So I am going for both the expert. Then I want to introduce the expert CV then to the audience. Then we will start with the first case, calling the student as well as both the examiner. Right. So I am going with the. So Dr. Sonia Madam's special achievement is she is the faculty and founder member of AMF, BLS and ACLS, SLS instructor, faculty in various workshop and national conferences. She is the examiner with NBE and various state universities. Total number of index publication is over 50 in national and international journals. And our next external examiner is Dr. Indrani. Just give me 1 second. Dr. Indrani Hemant Kumar is the professor and head department of anesthesiology at St. GS Medical College, KM Hospital, Mumbai. She has more than 31 years of anesthesia experience. First rank in DN MD anesthesia at Mumbai University. And she has 42 publications. She is the governing council member of MSc ISA for 2 years. And she has organized master class. She is the president of RSACP National and the past president ISA Mumbai. She was the organizing chairman of the ISACon 2011, and she is Bharat Jyoti Award and Natya Kendra Kala Mani Award winner. And coming to our intern, Dr. Ashok Kumar is the professor and head at the Nalanda Institute of Medical College, Patna. And she has vast experience in the field of anesthesia. He was also the head of the Patna Medical College. And the fourth examiner is Dr. Pratap Rudra Mohanty. He is my friend from Tata Main Hospital, Jamshedpur. He did his MD from the All India Institute of Medical Science. He has more than 10 publications and special interest in the intensive care as well as the pediatric anesthesia. And he has vast experience of giving lecture at various places. So coming to the case, we have two cases today. I would like to introduce the first case. Just give me 1 second. Sorry. And Nishant, can you introduce? Actually, my mobile is switched. Battery is down. Can you introduce the first case, the first exam, and this Nishant?
Yes, sir. So the first case is a case of primary gravida with the tight mitral stenosis presenting with the pregnancy. Term pregnancy. This will be presented by Dr. Surbhi. Dr. Surbhi is our student from AIMS Patna. And for this case, Dr. Indrani Hemant Kumar Madam and Dr. PR Mohanty sir, they will be taking up this case with Surbhi. So this will be the first case. It will be of approximately 30 minutes and at 15 minutes, we just given an indication, and then again after another 10 or so minutes, another indicator. So Surbhi, if you're ready, could you please start your case? Can you please share your slides? Yeah. So before Surbhi and Srishti, both of them, before they start their cases, I would really like to congratulate and thank both these presenters because it needs a lot of courage to present in front of all the every senior that is there in the Bihar Society and the Jharkhand Society, as well as such reputed faculty members like Sonia Madam and Indrani Madam and Mohanty sir and Ashok sir. So regardless of how you present Surbhi and Srishti, there is 3 cheers for you and 3 claps for you before you even start the case presentations. Okay, thank you.
Surbhi, don't worry. All the best to you. We are only here to help you.
Thank you, ma'am. Good evening.
Exactly. Surbhi, your audio is very low. Please speak loud.
Good evening, everyone. My moderator for today's presentation is Dr. Indrani ma'am and Dr. Mohanty sir. And my case presentation goes as follows. 24-year Muslim female, resident of Danapur, Patna, housewife by profession, belonging to low socioeconomic group, illiterate, was examined on 15th of March 2022. She presented with 9 months of amenorrhea with the following chief complaints. First, easy fatigability since 6 months, breathlessness since 5 months, and palpitation since 3 months. Coming to HOPC, breathlessness was insidious in onset. It was gradually progressive. And at the beginning of pregnancy, it was associated with ordinary activities, which later became symptomatic even while walking or going to washroom. It was relieved on taking rest. It was not associated with increased severity in lying down position or a loss of consciousness or nocturnal dyspnea, blood with sputum, fever and cough, pedal edema or ascites, or any seasonal variation or exposure to dust. Palpitation was abrupt in onset. It was first noticed in 3rd trimester. It was self-terminating. It had waxing and waning course, and it was associated with sleep disturbances. It was not associated with giddiness or syncope, sweating, chest pain, fatigue, or any drug intake, emotional stress, or psychosomatic disorder. Next, easy fatigability. Easy fatigability was insidious in onset and gradually progressive. She first noticed uneasiness while climbing upstairs in her 1st trimester, which progressed to fatigability while bending down or searching for objects. It was aggravated on doing strenuous work, and it was relieved on rest. Past history. Patient remembers of an episode of fever with severe knee and hip pain in childhood around the age of 10 years, and no details are available for the treatment. Medical history. She does not give any history of tuberculosis, diabetes mellitus, hypertension, bronchial asthma, or thyroid. There is no past surgical history. There is no history of chronic drug intake. There is no history of dysphagia or change in voice. There is no history of hemoptysis, no history of pedal edema or ascites, no history suggestive of subacute bacterial endocarditis, no history of involuntary body movements or painful digits, and no history of any hospitalization in the past. Ma'am, shall I stop here?
No, you continue. Okay, if you want to stop, okay, you can stop here, no problem. Okay, one small advice now. See, you have written, you can say that patient is having, what is that? Breathlessness.
Yes, ma'am.
Increased severity on lying down. So you please call it as orthopnea. Because here you can, in history of present illness, you can convert your breathlessness to, you can say dyspnea, orthopnea, PND, all these words should be used now. Okay. So your patient has got orthopnea and no paroxysmal nocturnal dyspnea, or patient has PND. Okay, that is one thing. And another thing which I would want you to say is about in your past history. You finished your past history, right?
Yes, past history.
So in your past history, you have to, you've spoken about chest pain.
The patient did not complain of any chest pain, ma'am.
No chest pain, right? So you have to talk about chest pain. And you have to talk about cough, hemoptysis, then embolic, subacute bacterial endocarditis, you have said, but it's always better to talk about embolic episodes. Whether the, and I think you have said loss of consciousness. Okay, fine, no problem. And otherwise, I think.
Okay. Basically, whenever you are presenting a case, this history, once the history is finished.
All right. Drug history, have you written?
Drug history and immunization history is also not there. With the pregnancy, you have to tell about the immunization history also. That is important. And think once you've taken up the history, then on the basis of history, you should know in which system it is involved. That is how the exams goes. Once you have taken the history, then you particularly go for an examination. So what are the positive points, positive history in these patients? Number 1, number 2, number 3.
Breathlessness with palpitation.
Yeah, breathlessness and palpitation. Okay. So breathlessness can happen in your respiratory cause or cardiac cause. Why it is a cardiac cause? Why it is not a respiratory cause?
So as such, I don't have any positive history for cardiac cause because the cardiac origin should have at least orthopnea or PND or features of right-sided heart failure. But ruling out respiratory causes, the patient does not complain of cough, or he does not complain of fever, or patient is not having any etiological factor for COPD, or he does not have any seasonal variation or exposure to dust. So that rules out my respiratory causes.
Yeah,
or there's no history of weight loss suggestive of malignancy or tuberculosis.
Yes. So you have to find out it is not of the respiratory origin. It is basically the patient has a history of easy fatigability, breathlessness, and palpitation, which is actually pointed out towards the cardiac. If it is a respiratory one, then there are chances of patient has a chronic history as well as it's a seasonal variation and all. Okay.
Yes. So why should there be breathlessness in this patient?
Could be because of pulmonary edema, ma'am, or pulmonary hypertension. She could have developed.
So, okay, that is one of the main reasons of pulmonary. Yeah, you're right. One is because of increase in pulmonary artery pressure. So you can have breathlessness because of that. What are the other reasons, especially in your patient? Because your patient is a pregnant patient, right? I'm just giving you another clue.
So diaphragm goes up, so she'll have difficulty with breathing.
Yes. What else? Do you think this patient is having anemia of pregnancy? There could be something called anemia of pregnancy.
Yes, ma'am. Yes,
right?
Yes, ma'am.
So what about oxygen consumption?
That will increase, ma'am.
Oxygen consumption goes up. So all these are reasons why patient has breathlessness. So that is why they push from one NYHA grade to the other grade during pregnancy, right?
Yes, ma'am.
Okay, go ahead.
So go to the examination.
What is the cause of easy fatigability?
Low cardiac output state.
Yes.
Oh.
Obstetric history, she is gravida 1 with no live birth and no abortion, and no ANC visits have been done. No previous pregnancies. Coming to menstrual history, she attained menarche at the age of 13 years. Cycles were regular and it was not associated with clots and pain. Coming to a drug history, no history of intake of any anticoagulants, diuretics, beta blockers, or any other drug in the past. And there is no history of allergy.
No question of in the past. Is she taking beta blockers and diuretics now? In all probability, yes, because this patient is having breathlessness, palpitations, right?
Actually,
so she will be on beta blockers. She will be on beta blockers in all probability as well as diuretics.
Absolutely true. If the patient is having palpitation, it's a palpitation is continuous or an intermittent palpitation?
Intermittent, sir.
Even then. What is the cause of palpitation?
Atrial fibrillation, ma'am, when it comes to...
May not be atrial fibrillation, just SVTs, supraventricular tachycardia.
Yes, ma'am.
Or it could be atrial fibrillation. Any supraventricular arrhythmia it could be, basically, right?
Yes, ma'am.
And also pregnancy itself can cause tachycardia, right? So, so all this could be the reason, but most likely your patient is on beta blockers and diuretics. Remember that. Okay, next.
Coming to personal history, mixed dietary habit. There is no history of smoking, tobacco, or alcohol consumption. Normal bowel and bladder habit. Disturbed sleep in third trimester. There is no significant family history. Coming to general examination, the patient is thin built, weight is 40 kg, BMI 17.34, pinkish purplish cheeks. She is alert, well behaved, conscious, and cooperative, well oriented to time, place, and person, sitting comfortably on bed. Pulse, it is 70 per minute regular, normal volume, all peripheral pulses are palpable. There is no apex pulse deficit, no radial or radiofemoral delay. Blood pressure 120/70, right arm, left lateral position. Temperature 98.1 Fahrenheit. Respiration 14 breaths per minute, abdominal thoracic, and saturation is 98% on room air.
Do you think JVP is important in your case?
JVP I mentioned, ma'am, in CVS examination.
No, all these are vital signs. What you're talking is all vital signs, right? So
Okay.
it should come in your vital signs.
It should come in the general examination, definitely.
Okay, ma'am.
Okay, go ahead.
Yes, ma'am. Pallor is present. Icterus, cyanosis, clubbing, edema, lymphedema, edema, and dehydration is absent. Coming to airway examination, on inspection, no obvious facial deformities are seen and there is no facial edema. The length of upper incisor is 1.2 centimeter. The inter-incisor distance is 4 centimeter. There is no buck tooth. Subluxation is absent. Myelopathy score is 2. Palatal configuration 4 centimeter. Head and neck movement within the normal range. TM distance is 6 centimeter and Lemon score is 2. On spine examination, lumbar lordosis is noted. Coming to systemic examination.
One more thing you should talk about here is Allen's test, modified Allen's test.
Yes, ma'am.
Okay. So what is modified Allen's test?
Modified Allen test, we test two limbs separately, and what we do is we basically obliterate both radial and ulnar artery of each right and left hand separately, and then we for 30 seconds, and then we look for the signs of reperfusion. So it has 3 gradings: grade 1, grade 2, and grade 3. Grade 1 is reperfusion within 5 seconds, grade 2 5 to 9 seconds, and more than 9 seconds is grade 3.
Right. But one important thing what you forgot to tell is you have to raise the arm first before you obliterate. Okay.
Okay.
First raise the arm and then only you should obliterate. Okay. Okay. Go ahead.
Cardiovascular examination. On inspection, there is no visible precordial bulge. Apical impulse is not visible. Precordium otherwise appears to be normal. No visible pulsations, no scars, no sinus, no dilated veins. There is no bony abnormality like kyphosis or scoliosis, and no raised JVP. Palpation, findings of infections were confirmed. Apex speed is confirmed. Tapping in nature in fourth intercostal space, 1 centimeter medial to the mid-clavicular line. There is no palpable parasternal heave or epigastric pulsation, no venous hum or carotid thrill. Auscultation, first heart sound is loud, second heart sound is normal. Murmur, it is low pitched, mid-diastolic murmur with pre-systolic accentuation, grade 3, rough, rumbling, heard with the bell of the stethoscope, patient lying in left lateral position at the height of expiration.
Okay. What is the cause of a loud first heart sound?
Ma'am, mostly what happens at the end of diastole, the mitral valves, they are in semi-closed position. So when there is decrease in size of the orifice, so there is wide opening of the mitral leaflets, and that leads to increase in first heart sound. Because of
your answer is only very partially right, because why is the leaflets why are the leaflets in a semi-closed not in a semi-closed position? That is because of left atrial pressure is already high. Yes. Isn't it? Yes, and the left ventricle has more time to accelerate, so the leaflets are still floating apart, right? Yes, it is akin to standing very close. See, if you're standing very close to the door, then you just have to gently just close the door like that, right? But if you're standing little far from the door and you have to close the door, what happens? You have to close like that, right? So which means it will produce a noise. So it is akin to that. So the leaflets are floating away because the LA pressures are high and LV has all the time to reach that pressure. So once that pressure is reached, then it bangs, it closes very fast. So that's how the first heart sound is Loud. Okay. And then you say, is there an opening snap in your patient?
I could not appreciate, ma'am. But usually,
Second question, they can ask why it is not a pan-diastolic, why it is a mid-diastolic murmur.
that depends upon the severity of the stenosis, basically.
No, it's not like that. It's always a pressure difference. Understand? So why it is, what happened in the left ventricle when it relaxes, it goes as isometric relaxation. Okay. So once the pressure in the left atrium decreases, then only the flow from the left atrium goes to the left ventricle. That is why initially the pressure is same. Until and unless the pressure of the left atrium is more than the left ventricle, then only the blood flow. That is why you get a mid-diastolic murmur. Yeah, like the others, like VSD, there is always a difference between a left, right ventricle and left ventricle. So you get a pan-systolic murmur because there is a difference. That is why it is all the murmurs is because of the pressure difference. You have to know each and every pressure difference of each chambers of the heart.
Can the first heart sound not be loud in mitral stenosis?
Yes, ma'am. It is. If it is calcified or if it is associated with MR, it will be.
Or if it is very severe.
Yes, ma'am.
Okay. It can be, it may not be heard. It may not be very loud. What is the cause of opening stenosis? So the very fact that the first heart sound is loud, it gives you an information. What information does it give you?
That it is still mobile and pliable.
Yes, mobile and pliable. And what about presence of opening snap? What is it due to?
Ma'am, it is because of the absence of inward doming of the mitral valves towards the left ventricle. We hear
it is because of the sudden tensing of the subvalvular apparatus.
Yes.
That is why you get the opening snap. Again, it gives an indication of a very pliable valve. Okay, you can go ahead with next
Yes,
slide.
ma'am. 17 minutes over, ma'am.
Oh, wow. Okay.
And Surbhi, it will be good if you could just switch on your camera. You know, we'll want to see you also. Is it possible?
No, it's okay. Let's leave it to her. What about your diagnosis, Surbhi?
It's okay. It's okay.
Let's quit all the other systems because I don't think you had anything with your other systems, right?
Yes, yes.
So what is your diagnosis?
Ma'am, my provisional diagnosis is MS in pregnancy, ma'am, because the patient had mitral facies on examination. She had a loud.
No, give your
S1.
diagnosis. What is your diagnosis? No. I'm not asking you reasons. What is your diagnosis? That's all.
Mitral stenosis in a pregnant lady, ma'am.
No, that's not the way you have to give. So you have to say rheumatic heart disease.
Summarize the case.
Mitral stenosis. NYHA grade? 3. Okay. And I'm surprised that your patient didn't have pulmonary hypertension. Parasternal key would have been there. Patient P2 would have been loud. They would have been, diastolic shock would have been there on palpation. I'm sure all this would have been there. Your patient is having orthopnea. Patient is having palpitations. So your patient has got pulmonary hypertension. So actually, patient has pulmonary hypertension, but in your case, you have not told anything about presence of pulmonary hypertension. So in your case, even considering that your patient didn't have pulmonary hypertension, you have to say no pulmonary hypertension. But I'm sure your patient has got pulmonary hypertension. Okay. So I have to say that patient is in normal sinus rhythm or atrial fibrillation, whatever you have found. I think your patient is NS normal sinus rhythm, right? Whether the patient is having failure or not, congestive cardiac failure, in failure, not in failure. Okay. All these things should come in your diagnosis. Right? So rheumatic heart disease, mitral stenosis, with or without pulmonary hypertension. Okay. Whether patient is having normal sinus rhythm, whether the patient is in failure, no embolic episodes. Okay, so no thromboembolism. So there are so many things which should come in your diagnosis. Okay, all right. So what investigations you will do? What is the most important investigation you will do? I'm not going to ask you about your blood investigation and all that. So what are the in your case? And now don't talk about, now let's not talk about a normal pregnant, this is a pregnant patient. So what investigation you will do in this patient?
Especially in this patient, apart from the other normal investigation, I would request for an echo.
Why echo?
What
is the
finding
importance
will
of
get in
echo?
echo?
I want to know the mitral valve area. I want to know about the ejection fraction. I want to know about the calcification or whether or not the patient had a thrombus in the left atrium. If I'm suspecting mitral stenosis in this patient.
Other than that,
Wilkins score? Okay.
About the pressure gradient.
pressure gradient, and then pulmonary hypertension also, that is considered in the echo. Okay.
So what is Wilkins score?
Wilkins score is, it depends upon 4, that is to know about the prognostic value after a mitral balloon valvuloplasty. And it consists of 4 parameters. First is leaflet calcification, then subvalvular thickening, leaflet thickening, and valve mobility.
Okay. So again, it is a score based on your 2D echo findings, right? 2D echo findings, and anything less than 8 is patient is very good for BMV, right? Okay. Now what is the grading? How will you grade mitral stenosis?
Grading can be done on 3 bases, ma'am. First is based upon mitral valve area. So based upon mitral valve area, if the area is between the normal MVA is 4 to 6. So if it is less, if it lies between 1.5 to 2, that is mild. From 1 to 1.5 is moderate, and less than 1 is severe.
Right. What is critical?
0.7. Less than 0.7.
Okay. What are the other parameters where you grade mitral stenosis?
pressure?
Pulmonary artery pressure, mean pulmonary artery pressure. So if it is less than 5 to 10, less than 5.
Gradient boulder. This is gradient, not PA pressure. This is what you are telling. It is
gradient. Yes, you have to talk about the gradient. Mild is gradient of less than
5.
5. Okay. Moderate?
Moderate 5 to 10. And
more than 10. Right. And the third one is pressure half time.
So pressure half time, mild less than 139. Moderate between 139 to 290. And severe more than 220.
Very good. Very good.
Have you any idea about the pressure uptime? What it is called?
Pressure
what is pressure uptime?
That is the time required to attain half of the transvalvular gradient pressure.
Very good. Good. And then the PA pressure also. PA pressure also mild, moderate, severe.
So even though X-ray is not very important in your case because you have to put an abdominal shield and all that. So here, what is your classical X-ray finding?
Classical X-ray finding will have straightening of left border of heart.
Why straightening?
Ma'am, because there will be obliteration of pulmonary bay. There will be increased size of left atrial appendages, and there will be right ventricular. The size of the left ventricular will decrease, and there will be LVH. So we'll have
not right ventricular hypertrophy. LVH will never be there.
Right ventricular hypertrophy.
Okay. Okay. See, when here the problem is mostly on the right side, right ventricular hypertrophy, right? But the patient, you can have a problem with a low ejection fraction in this case, but I don't think nobody will ask you these questions. But if anyone asks you about the left ventricle, you say it is chronically underfilled ventricle. And because of chronic low cardiac output, there could be myocardial ischemia. So that's why the patients can develop chest pain or patient can have low EF, right?
Yes, ma'am.
So that could be one of the reasons why you can have, but usually LV is never a problem. It's mostly the right ventricle, right? Okay. So let's quickly now jump to what is Karpreg score? Because your patient is pregnant, right? You've heard of Karpreg score?
Karpreg and WHO, that WHO scoring and modified WHO.
It estimates women's cardiac risk during pregnancy. So there are 4 risk factors. One is prior cardiac event, like heart failure or transient ischemic attack or a stroke or something like that. The second one is baseline NYHA functional status if it is more than 2. And the third one is left heart obstruction. That is, it could be mitral valve, it could be aortic valve. Here you already have a mitral valve problem, right? And reduced systemic venous, systolic function. So all these are parameters which can tell you the Karpreg score. That's why I asked you about the left ventricle. So here you only also talk about the ventricular systolic function. So it predicts the mortality. The mortality is 0 to 5% or up to 27% or more than or 75%. So depending upon the score, if you have more than one of these, the mortality can go all the way up to 75%. That is Karpreg score. Okay, what is the management?
The second reminder, ma'am.
What is the management? How do you manage this patient? Talk about medical and surgical management of this case.
Medical management will comprise of rate control, ma'am, that can be done by beta blockers. If she's having pulmonary condition, we can go ahead with diuretics. Then we need salt restriction in this patient, and we want bed rest, strict bed rest in patients.
Yes. Giving oxygen. Anticoagulation only if the patient is having
certain indications for anticoagulation. So only if this patient has it's a case of MS with atrial fibrillation, the patient is having any prior episode of embolism, or if the patient has left atrial thrombus, will anticoagulate this patient.
What anticoagulation do you use in pregnancy?
For the first trimester, it's we'll go ahead with heparin. But from 12 to 36 weeks of pregnancy, warfarin, and then we'll switch over again to heparin.
Definitely, if the warfarin dose is less than 5, it's okay. Otherwise, you go for a low molecular weight heparin.
Okay, what are the cardiovascular changes in pregnancy that can affect which can worsen mitral stenosis?
Now, increase in heart rate. So heart rate increases to about 20 to 30% increase is there. Decrease in SVR, increase in cardiac output, increase in blood volume.
Yes. Right. Then?
Cardiac output.
Systemic vascular resistance.
SVR decrease.
SVR, right. You said that. Oxygen consumption. Oxygen consumption also goes up. So automatically your goals during anesthesia is exactly remember whatever you said just now. So the cardiac output, so you have to, reduce the heart rate, increase the SVR, decrease the blood volume. So you should not give too much, you should not be too aggressive with fluids. So, and adequate preload. So all these are, just when you know what all should be your goals based on whatever you said just now, isn't it?
Yes, ma'am.
Okay, now what are the changes in cardiac output during the various stages of labor? Supposing now the patient is having normal labor, say. Now patient is not yet posted for cesarean, patient is already in labor. So what happens in this patient of mitral stenosis?
Ma'am, second stage of labor, there will be auto transfusion in this patient, so once the baby is out,
you need to talk in terms of what happens when there is sympathetic stimulation pain, and what happens to the cardiac output during the latent phase, what happens to the cardiac output during active phase, what happens to the cardiac output in the postpartum. It's a very, very important part of normal labor in a mitral stenosis case. So
and that is how the patient goes into failure in this part of postpartum area.
yes, so the latent phase, the cardiac output goes up by 10%. Okay, and in the active phase, it goes up to as much as 30%, and in the post expulsive phase, it goes up to 40 to 50%. And in the postpartum case, it can go up to 80%. Why 80% in the postpartum?
Autotransfusion.
Yes, autotransfusion can add up to it. Very nice. So when does the cardiac output normalize in these patients? After how many weeks? So it doesn't mean that, you know, immediate postpartum, the patient does well, the patient will do well afterwards. Because this increase in cardiac output persists for how long? For almost like 2 weeks. About 12 weeks or so. Yes, you're right. All right. Now coming to, you said about the medical management, right? So, and you also spoke about the anticoagulation and all that. Now, for vaginal delivery, supposing we are looking at vaginal delivery in your patient, which is severe mitral stenosis. So what will be your recommendation?
My first recommendation will be, I will suggest a labor analgesia in these patients.
Okay. See, because of want of time, we cannot go into the depths of labor analgesia in these patients. So you're talking about labor epidural analgesia or CSE?
Labor epidural analgesia.
Okay.
So what labor analgesia? Would you going to use CSE or only epidural analgesia?
Epidural analgesia, sir.
If you use combined spinal epidural, you can give intrathecal fentanyl, because if you have not given also the bupivacaine, it will be effective during the first stage of labor. So CSE ideally is a better choice, because the first stage of labor, the pain is coming from T10 to L1. So that can be blocked by your narcotics. So better to go for a combined spinal epidural, and the second stage you can use the local anesthetics.
Yeah, and in the second stage, you have to cut it short by giving a outlet forceps.
Yes.
And please don't forget these tenets in obstetric anesthesia of giving oxygen, giving left uterine displacement. Okay, these two, and of course, if you're talking about general anesthesia, then you have to talk about giving what? Avoiding acid aspiration. What do you give?
Anti-aspiration prophylaxis.
If it is a full
These
stomach.
three things are tenets of obstetric anesthesia. Never forget. Never forget. No matter what anybody is talking, whether it is labor analgesia, whether it is CSE, whether it is whatever you're talking, these tenets don't change. So you have to talk about these three things. Okay. All right. So, supposing you're giving a patient has come for a cesarean delivery. Okay, so how do you manage a cesarean delivery in this patient? Your patient has got severe mitral stenosis, and your patient is having orthopnea. So what will be your choice?
So
Your patient has orthopnea, if I'm not mistaken.
If the patient comes at latent phase to me, so I'll start with my labor analgesia, and
No, patient has come for a cesarean delivery now. So what will be your choice of anesthesia?
She is in second stage of labor.
No, she is posted for cesarean delivery. She is posted for cesarean delivery.
And we have epidural in situ.
Your patient is having orthopnea, no? Patient is not able to lie down, isn't it? Is the patient able to lie down?
No.
What anesthesia are you going to give? You have it.
If your patient is able to lie down, you can talk of combined spinal epidural or epidural anesthesia. I can understand that. But your patient is not able to lie down, right? Why? Okay. Considering your patient is able to lie down, you want to give epidural anesthesia. How are you going to give epidural anesthesia? And why is your choice of epidural? Why not spinal? Why epidural?
Ma'am, epidural will have a gradual onset, so I prefer epidural over spinal.
Okay, not just that. There are other reasons to that.
We usually give graded epidural. Okay, what is the advantage of graded epidural?
So there won't be loss of Wilkins reflex, or there won't be sudden hypotension in these patients.
Yes.
Yes, you can.
Sudden decrease in the SVR will be not there.
Can I come in for a minute? Dear examiners, can I come in for a minute?
Okay.
Actually,
Yes,
we
sir.
have crossed 40 minutes. So can we have two more questions? Because it's already 42 minutes, 41 minutes.
Okay, okay. I'm just
Actually,
going to
we
tell
have
you
one more
certain
cases.
tenets. Yeah, just tenets of labor epidural. You just say that one thing is you can dial your epidural. You can also know how many segments you have to block. That is one thing. Do not use epinephrine and epinephrine in these epidurals. Also, because you can prehydrate the patient, rapid prehydration can be avoided with epidural. Okay, so all these are, and plus in all where you have to say hypothermia has to be avoided. So all these are important points in regional anesthesia. And what are the tenets of general anesthesia? What are your anesthetic considerations?
Maintain
Just give
SVR,
1, 2, 3, 4.
to prevent tachycardia, to maintain SVR.
Yes. Correct.
To prevent hypothermia.
So you have to avoid any increase in pulmonary hypertension. So that can be done by avoiding nitrous oxide, avoiding hypothermia, avoiding hypoxia,
hypercarbia, acidosis.
All these are okay. And what will be your choice of muscle relaxant?
Rocuronium.
Picuronium or rocuronium. Avoid histamine releasing. And what will be your induction agent? Choice of induction agent?
Etomidate.
Pardon?
Etomidate, ma'am.
Etomidate, correct. So supposing your patient develops rapid ventricular rate and suddenly collapses, how will you treat the patient?
Collapses.
Collapse means
Hypotension
the blood
with
pressure
rapid
comes
ventricular
down.
rate.
So blood pressure comes. If the patient is under general anesthesia, blood pressure sudden fall, and the heart rate goes up to 170, 180.
Chemical cardioversion, ma'am.
Not chemical, pharmacological cardioversion. So what will be your choice of drugs?
Amiodarone.
Okay, you can give amiodarone, no problem. Okay. One last question is on pregnancy with presenting for surgical. Patient is supposing the patient suddenly deteriorates and, in the ward, and the patient needs a surgery. Okay. So the anesthetic considerations for pregnant patient coming for bypass surgery. So remember, if the patient is having critical mitral stenosis, not able to, a patient is rapidly deteriorating, these are the patients who will go for a BMV, and preferably in the second trimester of pregnancy. Okay. And if the patient is in the second trimester, same as a non-pregnant state, except for the fact that there could be a fetal demise. Fetal problems can be there. That's all. Otherwise, the risks are the same for both. And if you're doing a pregnant patient open heart surgery, certain things are very important. One is maintaining temperature, maintaining the hematocrit, having a pulsatile bypass, and then maintaining the mean arterial pressure on bypass. All these are certain tenets when you're talking about pregnant patient coming for bypass surgery. Okay, for my MVR or any other. So remember, all these are important points when you speak about pregnant patient for open heart surgery. Okay. So I think you answered very well. All the very best to you. And congratulations, you will do well.
Very good.
Well done, Survi. First of all, definitely you are doing very well. And as Dr. Indrani Madam said, wonderful that you and Srishti came forward to present the case first time online. And BJSA is really happy to have you and Srishti as first case presenter. And our blessings with you always. Okay? And also wanted to thank the Indrani Madam and Dr. Mohanty. Wonderful. We also learned a lot how to take exam, because exam lena bhi ek art hai. It is not about showing our intelligence. It is all about. So thank you, Madam, and thank you, Dr. Mohanty.
Thank you, sir.
Thank you very much. Thanks.
Of the day, Dr. Arvinda Ray, and our scientific chairman, Dr. Dev Sanjay Nag, who was also the past president, immediate past president. I would request both of them to please come, please be online. Sorry, open your video and please say a few words. Dr. Arvinda. Dr. Arvinda Ray. Dr. Nag, are you there? Okay. So we are moving to the next case. For this, I would like to invite Dr. Neelam Sinha, who is the treasurer of our society. She will introduce both the examiner as well as the student. Dr. Neelam Sinha.
Thank you, Sarath. Good evening, everyone. So that was a very wonderful case presentation by Dr. Surbi. We are moving on to the second case presentation by Dr. Srishti Kindo. Srishti, are you there?
Yes, ma'am.
If you are comfortable, you can open up your video also. She is a second-year postgraduate student from Rajendra Institute of Medical Sciences, Ranchi. And for this, I humbly invite the examiners, Dr. Sonia Vadhavan. Ma'am is Director Professor from Maulana Azad Medical College and Associated Hospital. Her areas of interest are airway and obstetric anesthesia. And she is a faculty and founder member of many associations like BLS, ACLS. She is instructor. She is faculty in various workshops and national conferences. Ma'am is examiner of national board and various state universities. She has a large number of publications in Index Journal, both national and international. Then we have Dr. Ashok Kumar. Ashok Kumar, sir is present. Ashok Kumar sir is professor and head of department of Nalanda Medical College and Hospital, Patna. He has keen interest in academics, and the PG students are really benefited with his knowledge. He has a number of publications. I invite Ma'am Sonia Vadhavan and Dr. Ashok Kumar to kindly start the session for case presentation by Dr. Srishti. The time allotted for the case presentation is 10 minutes, Dr. Srishti, 20 minutes for the discussion by examiners, and at the end for 2 minutes is open discussion by the forum present. Handing over to you, ma'am and sir.
Thank you so much, Dr. Neelam. Very good evening to everybody. And thank you for giving me this opportunity, Dr. Sharad and Dr. Nishant. And I would like Dr. Ashok to say a few words before we start.
I am thankful to everybody. They have provided me opportunity and opportunity for interaction among the national faculties, and I think it will be proper time to start the case so that time is not lost. Okay.
Dr. Surbi has done an excellent presentation, and Dr. Shrishti, please look forward to the presentation.
Thank you. Good evening, everybody. My name is Dr. Shrishti Keblu. I'm PG second year from Sati, and my moderators are Dr. Sonia ma'am and Dr. Ashok sir. So my case today, Mr. Jagmohan Pal, a 61-year-old male, is a resident of Ranchi and a manual labor by occupation, is of a low socio-economic status, is presenting with the following chief complaints: yellowish discoloration of eyes since the last 3 months, itching all over the body since the last 2 months, change in color of stool since last 1 month, and pain abdomen since last 10 days. The history of present illness: he is having yellowish discoloration of the patient was apparently symptom-free 3 months back when he noticed yellowish discoloration of eyes, which was insidious in onset, gradually progressive in nature. Yes, the intensity of yellowish discoloration increased over the past 3 months, appearing first over sclera and later over skin. The yellowish discoloration was light yellow initially, but has now become deep yellow. It is also associated with itching all over the body. History of present illness: change in color of stool for 1 month. He has noticed that his stool is clay colored since last 1 month. History of present illness continued. He has pain abdomen for the last 10 days. Site is right upper part of abdomen. Severity is mild, onset is gradual, and character is dull and keen. Duration since the last 10 days. Aggravating and relieving factors are none. The nature of the pain is non-colicky, and there is no radiation anywhere in the body. Associate this pain and the other symptoms are also associated with anorexia and significant weight loss in the last 4 months. He could eat 3/4 chapatis and rice earlier, but his appetite is decreased and he's having aversion to food now. The patient has no history of high-grade fever with no history of blood transfusion prior to the onset of jaundice. He's not a known drug abuser. He's not sexually promiscuous. No change in bowel habits and no bleeding per rectum. No history of hematemesis, hemoptysis, melena, sensation of fullness following meals. There is no history of headache or convulsion. Past history: there's no history of hypertension, diabetes mellitus, thyroid disease, tuberculosis, or any other significant systemic illness. There is no history of jaundice in the past. There's no history of hematemesis, melena. No history of chest pain, hemoptysis, cough, or bony pain. No history of any surgical intervention. No history of prolonged medication intake. And there is no history of blood transfusion in the past. Personal history: the patient is non-vegetarian. Among his habits, there is no history of alcoholism. He has been smoking cigarettes, and the duration is 10 pack years. The last cigarettes that he took, about 5 cigarettes per day before coming to hospital about 1 week ago, and stopped thereafter. Tobacco chewing, 25 years. He has left tobacco chewing after admission to hospital 1 week ago. Family history: there is no history of any significant systemic illness in the family. No history of jaundice in the family. His parents died due to natural causes at an old age. He has 3 brothers and 2 sisters, all healthy and alive. Treatment history: patient is not on any chronic medication or treatment. There is no history of allergy to any food or drug. General physical examination: patient is still built, weight is 50 kg, BMI is 90.2 kg per meter square. Patient is conscious, cooperative, and well oriented to time, place, and person. Facies is normal. Decubitus, patient is sitting comfortably on bed. Gait is normal. General physical examination. General physical examination. Pallor present over the lower conjunctiva skin on name badge. Icterus is present, deep yellow in color. Site is over sclera, skin and mucous membrane. Cyanosis is absent, clubbing is absent, edema is absent. Lymphadenopathy, spadonavy, pamerethma, and ecchymosis are absent. General physical examination continued. Pulse is 67 beats per minute. Regular, fair volume or peripheral pulses are palpable. No apical pulse deficit, no radioradial or radiofemoral delay. Blood pressure is 120 by 70 millimeter mercury. Right was taken on right arm, sitting position. Temperature is 98.1 degree Fahrenheit. Respiration rate was 14 breaths per minute and was thoracoabdominal. SpO2 is 98% in room air. Neck veins were not engorged. Skin is yellowish discolored and scratch marks are present. Airway examination. On inspection, there was no obvious facial abnormality. Buck tooth was absent. Inter-incisor gap was 4 cm. Length of upper incisors 1 cm. Mandible protrusion test. Mandibular teeth can be protruded beyond maxillary teeth. Malumpathy class 2. Palate configuration, there is no arcing or narrowness. Thyromental distance 6.5 cm. Mandibular space compliance is soft. Mandible is soft to palpation. Neck thickness is 37 cm. Head and neck movement normal range. Systemic examination, abdomen. Contour of abdomen and scaphoid. Skin over abdomen, no scars, no venous engorgement. Umbilicus central and inverted, moving normally with respiration. No pulsations or visible peristaltic wave. Superficial palpation of abdomen found that abdomen was soft. Temperature over the abdomen, the skin was normal. Mild tenderness over epigastrium. No. Am I audible?
Yes, you are audible, Srishti. Please continue.
Just on the further systemic examination of the abdomen, on deep palpation, it was found that there was tenderness in the right hypochondrium and epigastrium. There was a palpable hard mass of 5 cm to 3 cm approximately, palpable in the right hepatic quadrant region, has smooth surface, well-defined lateral, medial, and lower margins. Upper margin was continuous with liver, has firm consistency, 5 cm below the right costal margin in mid-clavicular line, and 2 cm towards the lateral border of 2 cm from the lateral border of rectus muscle. The lump moves with respiration and has side-to-side mobility. Hepatomegaly was present. The liver is palpable 3 cm below the costal margin, smooth surface, and there is liver has sharp margin. There is no splenomegaly, and bilateral hernial orifices are intact. On systemic examination of abdomen, percussion, there was normal tympanic node all over abdomen. Liver dullness extending from 4th intercostal space to 3 cm below the right subcostal margin. There are signs of hepatomegaly. There is no other organomegaly. There is no shifting dullness or fluid thrill. On auscultation, there are normal peristaltic sounds and there is no added sound. Chest is not on CBS examination. Inspection was found that chest is normal in shape, size, and symmetry. Pericardium is normal in shape. Apical impulse is not appreciated. No engorgement of superficial veins. Carotid pulsations are visible. In palpation, apex feet present in the 5th intercostal space in mid-clavicular line. There is no parasternal heave. No appreciable thrill or pulsation in any area. On auscultation, normal S1, S2 heard in intensity and character in mitral, aortic, and pulmonary areas. Rate is 67 per minute. Regular, no missed beats. There is no murmur or added sounds. On respiratory system examination, On inspection, it was found that the chest was normal, anterior chest was normal in shape, size, and symmetry. The trachea was central, respiratory rate was 16 per minute, regular. The respiration was thoraco-abdominal, no accessory muscle were used, no nasal flaring or subcostal retractions. There is no visible dilatation of veins, swellings, supraclavicular bulge, or hollowing. On palpation, it was found that trachea was midline, chest circumference was 86 centimeter, normal chest expansion, no local rise in temperature, no focal tenderness. On auscultation of respiratory system, it was found that vesicular breath sounds were not normal in all areas of auscultation, no added sounds, no vocal resonance was normal. On percussion, it was found that the bilateral normal resonant percussion was found. On CSNS examination, the person has normal behavior, normal cranial nerve and motor nerve examination was done. Superficial and deep tendon reflexes were normal. So my provisional diagnosis, Mr. Jagmohan Pal, a 61-year-old male, non-smoker and tobacco addict with obstructive jaundice due to malignancy, most likely due to periampillary carcinoma. Thank you.
Yeah, very comprehensive history and examination, Srishti. How do you say it is obstructive jaundice? What are the things positive in the history and examination which led you to this probable diagnosis?
Obstructive jaundice would be diagnosed by the patient has a history of clay-colored stool, first yellowish discoloration of eyes. That means the sclera has been deposited with bilirubin and bile salts. And skin has also been yellow color, and the stool is pale colored. So that means that the metabolism of it signifies how. And ma'am,
what does the clay colored stool indicate?
It indicates that stercobilin has not been present in the feces, which gives the typical color of the feces.
That is because the bile is not getting excreted into the intestine. It's not reaching the intestine because there is an obstruction.
Yes, ma'am.
Why you have the clay colored stool. Okay. What else?
The patient has itching all over the body.
What is that because of?
Because of deposition of bile salts, which give an itching sensation.
Okay. Causes a histamine release and causes the itching. So there is itching marks. There are scratch marks all over the body, and you said even in the examination of the abdomen that you could see the scratch marks. Anything else?
And ma'am, he has for obstructive jaundice, these three things are there.
Okay.
And for the diagnosis of periampillary carcinoma, features of loss of appetite and weight loss were significant. And he has a history of smoking.
Okay. So a significant weight loss. When do you say it's a significant weight loss? And how does the patient tell you that the patient has significant weight loss? Because that is something which the patient will tell you.
Yes, ma'am. This patient gave a history that his clothes were unfitting, that he cannot fit into his clothes. He did not weigh himself, but he is able to tell that he has lost weight.
So all these things are leading you to a probable diagnosis of the cause being of it being an obstructive jaundice. Why malignancy and why not a benign etiology? What are the causes of obstructive jaundice actually? Can you just broadly classify them?
Yes, ma'am. Causes of obstructive jaundice may be in the lumen of the gallbladder. These are extrahepatic. They may be found in the lumen or in the wall or outside the wall. They may be gallstones, parasites.
Okay.
And there may be stricture, which may be benign or malignant.
Okay.
And in the wall, it may be Caroli's disease, sclerosing cholangitis, And outside the wall, it may be carcinoma, most likely of head of pancreas or ampulla of beta, different.
So coming to the periampillary carcinoma, what are the various malignancies which come under this terminology of periampillary carcinoma? It's a broad terminology.
Yes, ma'am. Periampillary carcinoma may be of different origins. So it may be originating from the ampulla itself, or it may be inside the pancreatic, intrapancreatic distal bile duct, and it may also originate in the head of pancreas or in the duodenum.
Okay, very good. See, since we have little paucity of time, sometimes the examiners like to know how would you differentiate between pre-hepatic, hepatic and post-hepatic jaundice on the basis of your history examination and investigations. So you should be aware of that. And the other thing is that now this patient is going to present for a major surgery. And the one more important thing is that you said the onset of jaundice or icterus was over the last 3 to 4 months, but the pain is only of 10 days duration. So that's another thing which goes towards a malignancy where the history is short and the rapid progress of jaundice is more, and the pain may be because of an advanced stage in the cancer where either the nerves are getting involved, so the pain happens. So what is the surgery which the patient is most likely to undergo? Srishti? Am I audible?
Dr. Srishti? I think she got disconnected. We have to see. Just a minute, ma'am.
I am calling her. Just
Srishti, you are there. I think there is some issue with your network.
Christy, if you have any issue with your laptop, you can join through your mobile. Okay, you can give answer through your mobile. No, okay.
Might be a net problem also.
Dr. Srishti is having some issue with her laptop network, so she is joining through her mobile. Just give her some time.
Absolutely fine.
Yes.
Thank you very much, madam. During the meantime, I would like to hear from the Arvinder Ray sir, who is the chief guest. I don't know why there is some network issue or some sir has muted his mic. Arvinder Ray sir?
Yes, please.
Yes, sir. Welcome to BJSA, sir.
बोलिए
सर बस आपकी आवाज सुननी थी सबों को सर. You are the chief guest of the day, sir.
आवाज तो है, बुलंद है, नो प्रॉब्लम. सुन रहा हूं मैं. मेरे बोलने का अधिकार नहीं है, इसलिए सुन रहा हूं.
नहीं सर, आपको पूरा बोलने का अधिकार.
बैठे हैं, उनके अनुभव और उनके ज्ञान के सामने मैं रख नहीं सकता अपना हाथ, इसलिए मैं सुन रहा हूं सिर्फ.
ऐसी बात नहीं है सर. और
मुझे बहुत अच्छा लगा कि ये 2 डिफिकल्ट केसेस जो यूजुअली हर एनेस्थेसियोलॉजिस्ट एनकाउंटर करता है, उसी को आपने रखा है फॉर डिस्कशन. Excellent.
Thank you, sir. We also have Dr. Dev Sanjanar, who is our scientific chairman. I would like to hear him also. Dr. Dev Sanjanar.
Thank you for having me here. And it was a wonderful experience joining on this forum. And I think the courage of the two postgraduates who have joined in and made their presentation.
Your voice is, I think, breaking some network issue with you also.
Network
Srishti,
issue was
Dr. Srishti, have
there.
you
Yes, sir.
relogged
I'm
in?
here, sir.
Can't hear you. Srishti?
I'm here, sir.
Welcome again. Welcome again. Srishti.
Yes,
I'm here, sir.
yeah, Dr. Srishti. So
Yes, ma'am, I'm here.
This patient, what kind of surgery this patient would be posted for if it is diagnosed to be a periampillary carcinoma?
This patient can be posted for a Whipple's operation, ma'am.
Okay. Is it a major procedure or it's a?
Yes, ma'am, it's a major procedure.
Okay. So what are the, I mean, broad, what do the surgeons do in this procedure basically, just broadly?
Broadly, they remove the ampulla of Vater and the head of the pancreas and the part of the duodenum and part of the bile duct. And then there's a hepatopancreaticojejunostomy done.
Yeah, so basically first they remove the tumor, which includes all
First
these
they remove the tumor
organs, and then they do the 3 anastomosis. So it's a pretty long procedure. Since they have to connect the stomach to the jejunum, the bile juices have to go into the jejunum and the pancreatic juices have to drain there. So so it's a major procedure. What kind of incision is given and is it relevant to the anesthesiologist? It's called the rooftop incision. Okay, so it's an inverted V. It's a big incision, and it causes a lot of post-operative pain. So we need to take care of the perioperative pain in these patients. So now, since this patient is going to be posted for a Whipple's procedure, what are your broad concerns on the basis of which you will investigate and optimize this patient prior to surgery?
Prior to surgery, coagulation profile will be deranged because of liver metabolism will be altered. And so acute
liver metabolism, or is it something else? You said that the bile doesn't reach the intestines, isn't
bile,
it?
yes,
It's an obstruction.
so it's the obstruction.
So the bile salts are required for digestion of fat.
Yes, absorption of fat and production of clotting factors.
So the fat soluble vitamins, what are the fat soluble vitamins which are dependent?
Fat soluble are A, D, E, K, and vitamin K will not be synthesized, so clotting factors.
So vitamin K dependent clotting factors.
Vitamin, yes, ma'am.
So which are those factors?
Those are factor 2, 7, 9, and 10.
Okay, very good. So there'll be a coagulopathy which will reflect which investigation. What investigation would you do for that?
Prothrombin time and INR.
Okay. So when I asked you the concerns, since you're going to have a major procedure, so there are some concerns because of the patient profile and some concerns because of the surgery. So the patient profile, you said very correctly, one is the coagulation, which you need to look into. Any other concerns in this patient?
There might be renal failure. So sometimes
that happens if the bilirubin goes very high and there is inadequate hydration, then the patient can go into acute shutdown. Yes. More important, so you maintain very good hydration.
Hydration should be maintained.
Yeah. These patients are more prone to infection. Why?
Yes, ma'am. Ma'am, because of ma'am, the immune system has been suppressed.
One can be because of that. Anything to do with the bile salts and bile acids into the intestine. So there is translocation of the bacterial flora. Yes. So E. coli is one of the more common organisms which can actually cause infection and sepsis in these patients. Okay. Anything else? So these are and in this patient, you said he's a chronic smoker. So there would be some changes in the respiratory system, though he seems to be quite well preserved, which may be there, and he has stopped smoking 2 weeks back. So some benefits would be there, some take a longer time to happen. And also he's a tobacco chewer. So what could have happened because of chronic tobacco chewing?
He might have bad oral hygiene.
Bad oral hygiene is one. What else?
There may be peripheral vascular.
So from our point of view, you've done an airway assessment where you found the mouth opening very good. So if they are chronic tobacco chewers, sometimes they have submucosal fibrosis. So that would have added to the problem. Okay. So keeping all these things, and then of course the surgery, you have said it's a major procedure. It's going to involve a lot of blood loss, probably a lot of fluid shifts, long procedure. It has its own problems. And with the liver already affected and all your drugs you have to take care of. So keeping all this in mind, can you just run through the investigations, enumerate them from the beginning? What would you do?
Complete, we start from complete hemogram and PT-INR, and with the platelet count should be done, and X-ray, ECG, liver function test.
Yeah, first we should finish, if you're doing a CBC, complete blood count, doing hemoglobin, TLC, DLC, will tell you also about the infection, about the platelet count, then the coagulation profile, along with the LFT. So your liver function test will take a precedence over the rest of the blood investigations and the other investigations. Okay. So what all would you do in the liver function test?
Liver function test will do AST, ALT, alkaline phosphatase, GGT, 5-nucleotidase, and
so this serum bill would be increased. It would be conjugated, or it would be conjugated, which is increased.
It would be conjugated, that is increased.
Okay. Okay. Good. And amongst the SGOT, PT, and alkaline phosphatase, which is an indicator of obstructive?
Alkaline phosphatase.
Okay. So, and then you would do a serum proteins, and you would do a PT-INR. Other investigations, other blood investigations. He's a 61-year-old patient.
So renal function tests will be done.
With electrolytes?
Serum electrolytes will be done.
What else?
And since he is a 61-year-old male patient, then we can do echo and.
So first you'd like to do ECG and
X-ray and then echo. Okay. And ECG just for since yes ma'am. And
so in this, all these basic investigations are normal. Okay. However, the PT-INR was 1.6. So what will you do? You still have 4-5 days to optimize the patient. You can't wait for too long. It's a malignancy and the bilirubin is worsening. So what will you do?
We can either go for injection vitamin K, IM for 3 days, OD, or sometimes we can give IV also.
What is the dose?
10 milligram IM.
Okay.
And we can transfuse FFP.
Okay. So normally if you have given vitamin K, it may normalize. If after you repeat it's not, then you can transfuse FFP. Okay. What else will you do to optimize this patient? We've already discussed. One was coagulation. The other thing you were worried about was the renal system. So what would you ensure for this patient?
We must ensure that the renal functions are normal.
Okay, that is fine.
And hydration is proper in this patient. That we don't want renal hyperperfusion.
Okay. What else?
And
what about the infection, sepsis? You like to start the patient on some antibiotic? The surgeons normally start the patient on some antibiotic. If there is possible to decrease the bilirubin, they can do that so that there is some distal passage of bile. So they do all that. So now you have done all the investigations and you have tried to optimize the hydration status. Initially, patient will take orally, but prior to surgery, you can go on to the intravenous fluids for ensuring adequate hydration overnight prior to the surgery. So what are your preoperative advice in this patient?
Preoperatively, have routinely, like according to guidelines, we ask the patient to stay NPO.
Okay.
And in the morning of the surgery, we can
So how
have
many
a quick
hours of NPO do you advise?
6 to 8 hours, ma'am.
Okay.
6 to 8. And in the morning of surgery, we can quickly reassess the patient. And if required,
when you go to see the patient, you had seen the patient before, you optimize the patient, then pre-operatively 1 day before you go and advise. So there are a few things which you do. One is the NPO, which is normally 6 hours, but this patient in all probability would be kept on overnight hydration and 6 hours.
we pre-operatively 1 night before, we can give him alprazolam 2.5 mg for anxiolysis.
0.25 mg. Okay.
And in the morning of surgery, we can do put PDINR repeatedly, because if his coagulation profile was deranged earlier, we can check on reassess.
So whenever you advise preoperatively, one is NPO, then is the type of consent you will take in this patient. So this patient comes in which ASA?
This patient is ASA2, ma'am. Sorry, ASA3.
ASA3. This is a high risk involved.
Yes, ma'am, high risk.
So you will take a high risk written informed consent where you will explain to the patient what are the reasons why the risk of the patient to undergoing the surgery and anesthesia is higher than any other patient who is of an ASA 1 or 2. Isn't it? After consent, you said it's a major procedure. What do you expect intraoperatively?
Intraoperatively, I can expect hypotension and hypovolemia.
So anticipating that in your preoperative advice, do you ask for something? Anticipating that it's a major procedure, there is a big tumor which is removed, there are 3 anastomosis. So there can be, you can expect blood loss. So
blood
you would
loss,
like
so
to
we can advise
blood
for
and also
arrangement.
For blood and blood products. So FFP
products.
would like to arrange. Okay. What else? So this is all your preoperative advice, NPO status, consent, arranging blood and blood products. Then you said you would like to ensure anxiolysis. You will also spend good enough time with the patient because the patient is already having a cancer, is undergoing a major procedure. You'll explain it properly. And then you will ask for some investigations on the morning, which you said you would like to repeat a PTINR. That is fine. Okay. On the morning of surgery, after you have gone through the checklist and you have seen the patient, now you want to take the patient. How will you proceed? What is your plan of anesthesia?
The plan of anesthesia would be general anesthesia with controlled ventilation and
very good
epidural anesthesia.
Okay. So general anesthesia with controlled ventilation with endotracheal intubation and providing analgesia with epidural. What epidural would you give?
I would give
or lumbar, what?
Mid-thoracic, ma'am.
Thoracic, okay. Very good. So for with thoracic epidural analgesia for perioperative pain management, good. So you shift this patient to the OT. How will you proceed further?
Ma'am, when the patient is in OT, first we secure IV lines, attach all monitors, and ECG, pulse oximeter, BP, and temperature monitoring, temperature probe.
Okay.
And then we prepare the patient for epidural catheter insertion. So for central neuroaxial block, an epidural catheter is placed, and then the patient is in. So we can also go for Cvp monitoring, and
okay. Yes,
we
should go
start.
for CVP monitoring in this patient. The patient is undergoing a major procedure. So after baseline, your vital assessment with NIBP, pulse oximetry, ECG, and temperature, you can secure an IV line, which is normally a wide bore IV cannula. What fluid do you connect to?
IV cannula would be a large bore cannula.
Yeah. What fluid do you use? Do you start?
We can use RL.
Okay. Okay.
Fingers lactate.
Okay. Any role of invasive BP monitoring in this patient?
Yes, ma'am. Because intraoperatively there are chances of hyperperfusion and hypotension.
Okay. Why are these patients prone to hypotension and bradycardia?
Ma'am, because there is a decreased total circulating volume because of decreased cardiac output. And
in fact, there is a decrease in the peripheral vascular
resistance is also decreased. Yes, ma'am.
It's a hyperdynamic circulation. And what is the role of bile salts in this? Why is there bradycardia?
They directly act on the cardiac contractilities.
Yes, one is contractility is also decreased, and it also affects the SA node.
Yes, ma'am. It affects the SA
node.
node.
Also has a pulse rate of 67, and
that is
not such an old patient. He's just 61 years old, so you might have expected a higher. So he's got a pulse rate of 67. So you may have perioperative hypertension, and then you said it's a major procedure. So it's always good to do an IBP monitoring. You can also have serial blood gas analysis with it. Okay. So how will you pre-medicate? What will you pre-medicate, and how will you proceed further? Now you have put in a thoracic epidural for perioperative analgesia. You had secured an IV line, and you have done all appropriate monitoring.
We give one test dose of for epidural and analgesia, and then IV we start with H2 blocker, most probably ranitidine.
Okay.
We use 50 mg.
Okay. What else?
1 mg IV, and
this patient has a bilirubin of 14 milligram per deciliter preoperatively. Okay.
Yes, ma'am.
This patient has a bilirubin of 14 milligram per deciliter, and even the SGOT PT are almost in 200, about 200, 160 to 200 range. Okay.
So
after you've given H2 blocker, what else?
Midazolam can be given.
Okay, you can give a small dose of what? How much will you give?
1 milligram.
Okay.
And then we start induction. Pre-oxygenation starts with general anesthesia. Can be started with pre-oxygenating the patient with 100% oxygen.
What is the role of opioid? Any opioid you would prefer? Which is the preferred opioid?
Fentanyl is the preferred.
Okay. What dosage?
1 to 2.
I'm sorry to intervene. Can we conclude in 5 minutes?
Yes, we'll do that, Dr. Thank you.
Thank you, ma'am.
So you will induce with which induction?
I'll induce with propofol, ma'am.
Okay. So you give a fixed dose, or you give an incremental dose or a graded dose?
We give graded doses.
Okay. And you will achieve neuromuscular blockade with?
Atracurium.
Because it is?
0.5 mg per
kg. Why do you choose atracurium?
We choose atracurium because it is liver sparing, and
so it is independent. Its metabolism is independent of the liver.
Metabolism is
Hoffman's elimination. So you will avoid. You will not give vecuronium or rocuronium. You'll use atracurium or cisatracurium. Okay. Then you'll secure the airway, and preferably minimize the sympathetic stimulation in this case, because the more the sympathetic stimulation, so you can use a video laryngoscope and you will intubate with an appropriate size endotracheal, cuffed endotracheal tube. How will you maintain anesthesia?
Anesthesia can be maintained with sevoflurane and atracurine.
Okay.
Can also use nitrous oxide.
Okay.
Sometimes. And pain can be controlled with multimodal analgesia as well as epidural analgesia. And urine output can be monitored.
What will you give through the epidural route? How much roughly would you give?
I would give 0.25% bupivacaine and 6 ml, 6 to 8.
Okay. And you can titrate according to the...
We can titrate accordingly. Yes, ma'am.
You were mentioning something about urine output?
Yes, ma'am. Urine output has to be monitored so that we can assess the renal function and ensure that there is no hypoperfusion in renal system in the kidneys.
So what is your desired output? How much should be the desirable output?
It should be 1 ml per kg per hour.
Good. So you should preferably have it more than 1 ml per kg per hour. So you said you monitor the IBP, CVP, SpO2, ECG, temperature, urine output. Any other things you would like to monitor?
Neuromuscular monitoring.
Okay, neuromuscular blockade. If you have a neuromuscular monitor, please use it. Then intraoperatively, you have also monitored the temperature. What are you worried about?
Monitoring.
There is hypothermia. What happens? What are the problems of intraoperative hypothermia?
Ma'am, intraoperative. There may be patient may be
So what happens to the coagulation system? What happens to the drug metabolism? What happens to the myocardial irritability? Huh? So there are various effects of hypothermia. Okay. Now suppose you're monitoring the urine output and over the last 1 hour, 1.5 hours, it's only about 20-25 ml. So it's less. What will you do? What will you see?
We will assess the output and input.
Yes, you will see how much input is there. Good. How much you've given? What is the blood loss?
Blood loss, and we'll calculate MABL.
Yeah. So you will ensure that the fluids was adequate. What else can you do? Despite adequate fluid, sometimes you may not get. So what else can you do intraoperatively to ensure a good urine output?
IV, we can give either furosemide.
Okay, yes, you can give furosemide. You can give. How much would you give?
20 mg.
Okay. Anything else which is given? Which surgeons also prefer and was initially actually
mannitol.
Mannitol. What percentage? What dosage? It's an
20%
osmotic diuretic. 20%. So 20% means how much in 1 ml?
1 ml has 20 mg.
200 mg.
200 mg.
So you have about 0.5 to 1 gram per kg. So
1 gram per
kg.
kg.
Okay. Sometimes you can use dopamine also in a renal perfusion dose. Okay. So you have to monitor, like you said, urine output is important. So you maintain, like in the previous case we discussed, you maintain normoxia, normocapnia, normothermia. So, and you are maintaining analgesia with multimodal. You said you'll give epidural. What else for multimodal intraoperatively?
We can use tramadol and paracetamol.
Okay, so you use paracetamol. Okay. And
morphine can be given, but it should be avoided.
Should preferably be avoided. The role of morphine or fentanyl causing spasm of the sphincter of Oda is not of much significance. It's basically the metabolism. So if you have a fentanyl, that will be preferred over morphine in this case. At the end of the surgery, how do you?
At the end of surgery, ma'am, we ensure adequate neuromuscular reversal. Neuromuscular reversal should be done, and
so if you're having a neuromuscular blocker, neuromuscular monitoring, how much should be the TOF before you decide to extubate the trachea? Once the patient has to be conscious with reflexes intact, should have good
reflexes should be intact.
So good neuromuscular
should be greater than 90%. Yes.
Very good. It should be more than 0.9, the ratio of the fourth is to the first. And post-operatively, after extubating the trachea, where would you like to shift this patient who has undergone a Whipple's procedure? Patient has
we would preferably use an ICU and HDU. HDU monitoring should be done, ma'am.
Okay, either ICU or HDU, where there is more intensive monitoring. Any post-operative advice, any investigations you would like to repeat?
We repeat coagulation profile.
Okay. Even the hemogram coagulation profile, safety, electrolytes, yes. And you would take care of analgesia. How would you take care of analgesia in this patient now in the post-operative period?
We can use epidural catheter and we can use epidural analgesia.
Okay.
Repeatedly.
You can use an infusion. Either you can have those elastomeric pumps or you can use an infusion pump separately. Titrate the infusion rate in the post-operative period. Okay. And like there are certain scores like the MELT score and the Child's Book criteria. What are those used for?
Those are, ma'am, for assessment of severity of the liver disease.
Yes.
MELT score is mostly for malignant diseases, whereas a Child-Pugh score can be used for ascites, as well as Child-Pugh score has 5 parameters.
So these are the Child's Book criteria is mostly used for cirrhosis of the liver.
Cirrhosis, yes.
We are more prognostic scoring systems. So cirrhosis of the liver becomes a totally different long case discussion where there's portal hypertension. So we're not going, but you should be aware of this. And you should also be aware of how bilirubin is synthesized, what are the functions of the liver. So the examiner can, divert at any point from your obstructive jaundice, can ask some of these basic questions also. And I think we are running short of time. So depending upon the organizers, Dr. Ashok.
As internal examiner, I have found that the way of examination Dr. Soni has presented is nice. He has extracted everything from Dr. Srishti and she has touched every aspect of the management. And even if some points she has missed before, Dr. Srishti, as for example, in preparation, the use of some diuretics. Later on, Dr. Soni has extracted that also. So Dr. Srishti also has answered so coolly. Absolutely. And everything she has answered nicely. So I think, and I shall recommend Dr. Soni to give very good marks to her.
Yes, absolutely. Dr. Srishti has done a very good presentation and she has answered the questions, also handled them very well. And
thank you.
All the best to you and to Dr. Surbi for your exams.
Thank you.
Thank you, Dr. Sonia. Thank you, Dr. Sonia and Dr. Ashok Kumar. And sincere thanks to our speakers, this Srishti as well as Surbi, both of them presented so well. So before moving to the next step, I would request our examiners, Dr. Indrani Hemant Kumar, Dr. Sonia Vadwan, Dr. P.R. Mohanty, and Dr. Ashok Kumar to guide our PG students that how to prepare, what are the tips and what are the steps, how to prepare for the exam, what precautions they should take, especially the DNB examinations, because the students are really scared of DNB examination, that they don't know anyone. So just a few tips and from the examiners for our students.
I think Madam would like to first say.
Actually, see, DNB pattern of asking questions is in fact easier than other university examination. That's first thing I can tell you. It's a very structured questioning. Like how today we dealt with both the cases. Initially, you have 2-3 questions on, say, pathophysiology, clinical features, and things like that. Then they go into the anesthesia part. There are some structured questions of anesthesia, then post-operative, whatever complications. They're very structured questions. So unlike in MD examination, for example, you know, we can jump from one to another, right? So I can jump from, say, for example, supposing I say pregnancy results in, say, progesterone mediated increase in neural sensitivity of local anesthetics. I can jump into what are the other conditions where the local anesthetic sensitivities are increased. You know, I can jump into other things, right? Say, for example, you can, in your liver case also, you can, you know, you can jump into other systems. You can just stick to mitral stenosis, nothing beyond it. So therefore, you know, DND is much easier than the other MD examination. Definitely, there is no problem at all, and that's what I would say. And for studying, what I would say is have a proper plan, have a proper realistic studying you know, timetable. And if you have a friend, you all can have a common timetable. Get 1 hour to discuss with each other in the evening. Have a common timetable. Supposing you're doing cardiovascular system, you have a cardiovascular system starting from 1st to 7th is cardio, or 5th is cardiovascular system. So your friend can read from any book, but you will be reading cardiovascular system on those 4-5 days. And every day, make sure you all meet, shoot questions to each other so that, you know, by hearing the answer, you will register. You know, that way also. So that is, I would suggest that, because if you have a good friend, actually makes it easier for you to, you know, support each other mentally. Also, you support each other, and even study wise also you support each other. But even if you don't have a friend, doesn't matter. Have a very realistic timetable. Make quick notes, which are very important points, which you should not never forget in that particular quest, in the particular system. And what I would say is, for your theory, have a master chart of your answer. You don't have to write everything, just the headings. Have a master chart of that answer, especially for important questions. Have a master chart for that. And I think you are going to be the topper.
Dr. Sonia, you want to say something to our PG student? And I'd request our PG student also, if they want to ask something, if they have any difficulty, they can ask our teachers.
So like Madam said, I agree, DNB has become very streamlined in a way. It is to make it absolutely systematic and same in all the states. So the other advantage presently with the COVID situation having come, OSCE became a medium of assessment in the practicals. So it is pretty scoring if you read up the clinical scenarios and you have a good approach to the OSCEs, you know, half your work is already done. So only it's about 50% which is left for the practical vivas. And there are now, that is also divided. One question was in the time before the last one. they had given the detailed questions, what you are supposed to ask the students, and all the students were asked that single case scenario. So in DNB, it is pretty streamlined. And like ma'am said, in the other state exams, it may vary, and the examiner can switch from one part to the other. And the student should be aware that it may not be possible to answer everything. But if you don't know something, do not try to answer it and give wrong answers. Instead, it's easier to accept that I don't know this, so that the examiner can ask you more questions. There is limited time in which to assess. And also, whenever they are presenting, they are talking about some clinical findings, they should be able to substantiate it in case the examiner decides to ask, how did you look for this? So those are some of my suggestions. And yes, like ma'am said, there is no replacement for case discussions. You discuss with your friends, with your seniors, with your colleagues. If you present it more, you overcome that hesitation, because you only have that half an hour to show what you know to the examiner. So you may be clinically very good, but you may be a little hesitant in speaking. So you need to speak out and discuss more. And there are always a defined number of long cases and short cases, which are mostly there. There may be 1 or 2 exceptional cases depending on the location. So if you are prepared for those 10, 12 long cases and those 18 to 20 short cases, I think most of the problem is solved. That's.
Thank you, ma'am. Thank you. Dr. Ashok, your suggestions for our students?
Yes. Be it DNB examination or MD examination, the knowledge is the most important thing that is to be applied in practical aspects. And in this, it is important to get interaction with the teachers. Mostly I find that students don't ask questions to their teachers during operation or even during academic activity like case presentation. The students become shy to ask the question. So this should not be happening. That questions should be asked to the teachers, that make a very good interaction. And also the students should interact with each other. Another thing I shall recommend that there are a lot of books in the market, and every book, none can go through every book. So one precise book should be chosen by the candidate, and he should go through that, rather to wander this book and that book. So in one book, he can make a structure of the subject matter if he goes through one book. Just like Miller, everybody can't control Miller. So one has to go through the precise book. Any book, I have got one book, Essential Clinical Anesthesia. I have found it very good book. And every aspect is there. Clinical aspect is very nicely dealt with. So candidate must select one book and he should go through that. And if any confusion is there, he should interact with first with the teachers and then only go to other reference book, etc. So this will be my suggestion for the students.
Thank you, sir. Thank you, Dr. Ashok. And it is really true that these days we find that students, they do not ask questions. We keep on asking them questions. Dr. Mohanty, your comments, please.
Yeah, basically, if you think of that, if you talk about the DNB is now a very structured one. The OSCE based exams are now coming, but then you have to pass this case also. You have to pass the case as well as the OSCE. Second thing, you should always choose one book. That is very important. You can add on it, and you make single book and all the references you put, get the points and add on it. So final revision is much more easier. It is my experience because one of my colleagues is in UK now. He read only that Morgan and he compiled in the Morgan. Finally, when I am preparing, I am at a loss at the time of exam. So one book should be there for the final and you add on it. That is the best one. And definitely it is the OT teaching that matters. Inside the theater, you always teach the postgraduates. That's what we are calling in the All India Institute is corridor teaching. We are afraid of going into the corridor because seniors will take up and they'll ask questions. So the OT teaching matters and definitely the case presentations, and it is very, very important it is a very, very good initiative by our ISA Bihar Jharkhand. I think we should continue this. So then our postgraduates also get much more benefited with this. Thank you.
Thank you, Dr. Mohanty. And we are really happy with the initiation of this case presentation series. And we are so happy to announce that our PG students, they themselves came forward for the presentation. So I think we will continue with the case presentation series after our 1-year series of CMEs. So now it's time for felicitations. I will request the examiners to felicitate their students, Dr. Indrani Hemant Kumar and Dr. P.R. Mohanty. Let me first share my screen. I would request Dr. Indrani and Dr. Mohanty to present a certificate of appreciation to our student, Dr. Surabhi. This is an e-certificate. Dr. Indrani and Dr. Mohanty.
How to do that?
Just say and we will send them the certificate. The certificate is presented to Dr. Surabhi.
Okay. All the best, Surabhi. It's an excellent presentation. And definitely you are a very knowledgeable student, no doubt about it. And will pass with the flying colors.
Thank you, sir.
I would request Dr. Sonia and Dr. Ashok Kumar to present this certificate to Dr. Shrishti.
Okay, Shrishti, you have presented nicely. All of us are very satisfied with this. So you deserve this certificate and we present this certificate to you. And best of luck to both of you. Thanks.
Thank you, sir. Thank you,
very well presented, Dr. Shrishti, and keep it up and keep studying, keep working. And I'm sure you'll come out with flying colors, and best wishes to both of you. And thank you for giving us this opportunity. Thank you.
Thank you, ma'am.
Now I would request our President, Bihar Jharkhand Society of Anesthesiologists, Dr. Dinesh Kumar, to felicitate our examiners. Dr. Dinesh Kumar. Dr. Dinesh Kumar, sir, are you there?
Yes, madam.
I would like to request you to felicitate our examiners, Dr. Indrani Hemant Kumar.
I am honored to present our certificate of appreciation to Dr. Indrani Hemant Kumar. Madam, please accept from our side.
Thank you very much. My pleasure. Thank you so much for having us here.
This is our honor, madam. Thank you. Thank you, Neelam.
Sir, please present to all the examiners. Dr. P.R. Mohanty.
Mohanty, sir. Dr. Mohanty, sir.
Yes, sir.
Hello.
Hello, हाँ sir, बोलिए.
Dr. Mohanty, sir, please accept. Sir, please appreciation, sir, from the BJSA.
Thank you, sir. Thank you very much.
Okay, thank you, sir.
Dr. Sonia Vadhavan.
Hello, madam. From the BJSA, kindly accept our certificate of appreciation, Sonia madam. This is our
Thank you so much,
CME
Dr. Dinesh. Thank you.
Thank you, madam. Thank you.
Dr. Ashok Kumar.
Dr. Ashok, sir.
Yes.
Dr. Ashok, sir, pranam, sir. And please, yes, sir, and please accept our certificate of appreciation for attending this CME. Thank you, sir.
Thank you, Dr. Dinesh.
Dr. Ashok, sir. Please accept.
Thank you,
Yes,
Dr. Dinesh. I am accepting and congratulating you for starting such a nice thing and continue it.
Thank you, sir.
So that students are being benefited and we also are able to interact with each other.
Sure, sir.
Thank
sure,
you.
Sir. Okay, sir. Thanks very much.
Thank you,
Over
sir.
to Neelam. Dr. Neelam.
Yes, thank you, Dr. Dinesh sir. And I would now request our chief guest and guest of honor, Dr. Arvind Ray sir, are you there? Dr. Arvind Ray?
Perhaps he has left.
Okay, Dr. BK Prasad sir, we would like you to say a few words for our presenters, our examiners.
Our guest of honor.
First I will start from presenters. Dr. Surabhi and Dr. Srishti. Although Srishti has to face examination very soon, Surabhi has to face examination very soon because she is in third year. And her presentation was also very good, and talk was also very good. Slides were nice, and she faced the viva very nicely. Very, what I should say, acutely she had answered. And in my opinion, when she is hesitant to say anything, then it is better to say just sorry, madam, or I don't know, so that the examiner can switch over to the other part. That will be better. Regarding Srishti, she should develop her voice, and other things were almost normal or better. Due to link, there was some gap, but this is not her fault. It was the technical fault. Anyway, all the four examiners were very sincere person, very nice person, and Professor Ashok Kumar also pointed out the few things very nicely. Dr. Mohanty is well known here. We all know about Dr. Mohanty. Dr. Vadhwa and Dr. Indrani, I have just first met her, and both were very, very nice, very gentle to the examinees, and they have guided us very nicely. Although I should say that I have also experienced some new things, how to examine in better way. Thank you, madam. Thank you all. Thank you, Ashok sir. Thank you, Mohanty sir.
Thank you, everyone.
Thank you, sir. Thank you, sir.
Thank you, Dr. BK Prasad sir. Now we come to the end of this session, and as a customary, I am presenting the vote of thanks. My sincere thanks to our chief guest, Dr. Arvind Ray, ex-GC member of ISA National. Our guest of honor, Dr. BK Prasad sir, past president, Bihar Jharkhand Society of Anesthesiology. Few guests present here, Dr. Sukhdev Nayak from Odisha, sir is present here. Sir, sincere thanks for being with us. Our examiners, Dr. Indrani Hemant Kumar, Dr. P.R. Mahanti, Dr. Sonia Vadhwan, Dr. Ashok Kumar. Thank you, sirs and madams, because without your presence, this session would not have been successful and so interesting and so beneficial for the students. And thank you so much. Special thanks to our presenters, Dr. Surabhi and Dr. Srishti. Both of them presented so well. And I would request all the PG students to come forward and to present the cases and ask your seniors, ask your examiners, ask your seniors as many questions as you can. My sincere thanks to Dr. Dev Sanjay Nag, the chairman of scientific committee, Dr. Nishan Sahai, scientific coordinator, Dr. Manoj Kumar, our ex-GC member, Dr. D.K. Singh, the president, Bihar Jharkhand Society of Anesthesiologists, Dr. Sharad Kumar, secretary, Bihar Jharkhand Society of Anesthesiologists, for coming up with such great ideas of academic sessions on this virtual platform. And I'm happy to say that throughout the COVID era, we continued with our CME on the virtual platform. Not a single month we were without our CMEs. And for that, we are really thankful to all the organizers and the members of Bihar Jharkhand Society of Anesthesiologists and under the guidance of our seniors. Thank you so much, sirs and madams. And we hope to continue with this same session, and we would love to meet all the examiners again and again for the benefit of our students. Thank you, sir. Thank you, madam.
Thank you.
So shall we conclude, Nishant?
Thank you. Thank you. Thank you, and good night to everyone.
Yes, ma'am. Thank you so much.
Yes,
and
thank you, and good night to everyone.
Yes.
Thank you, ma'am.
Thank you, ma'am.
Thank you, sir.
Thank you, sir. Thank you.
Good night, ma'am.
मैं सोच रहा था एक आध मिनट टाइम मिलता अशोक सर और डीके सिंह से बात करने का।
Yes, sir.
हाँ, ready, sir?
Thank you.
Members of Bihar Jharkhand of Society of Anesthesiologists can continue.
Yeah, that's better. निशांत जी को पहले धन्यवाद दिया जाए कि इन्होंने अभी तक इसको संभाल के रखा है एक शब्द में, और शरद को दिया जाए धन्यवाद कि शरद कम से कम उसको बूस्टअप करके एवरी मंथ एक न एक टोन में कहीं न कहीं से कुछ न कुछ खोज के ले ही आता है ना। मैंने जो मेरी फीलिंग है मैं बहुत अच्छी तरह से फैमिली जैसा बता रहा हूँ। प्लीज सिंह साहब के काल में, मतलब इनके प्रेसिडेंसी में ये एक नया चीज का हम उनसे रिक्वेस्ट करेंगे, ऑलवेज रेडी टू हेल्प एट एनी टाइम एट एनी पॉइंट, कि इसको कंटिन्यू करें। अगर ये 12 से 24 हो जाए पीजी टीचिंग तो और अच्छा है, फोर्टनाइटली भी हो जाए तो कोई नहीं तो कम से कम हम और अशोक सर तो जरूर खड़ा मिलेंगे कहीं। क्या अशोक सर?
डेफिनेटली सर।
2 आदमी तो कम से कम हमको 100% उम्मीद है। बाकी लोग बहुत बिजी हैं, हम जानते हैं सब लोग बहुत बिजी हैं, लेकिन हम लोग उसमें से टाइम निकालने वाले हैं सब काम छोड़ के। अशोक सर तो केस भी पोस्टपोन कर देते हैं कि अरे आज ही काम है, नहीं जाना है। तो इसीलिए हम लोगों को उस तरह से ये जो आया इतना अच्छा लगा, और इतने लोग, ये 2 केस आया ना, अब देखिए आपको अगले वीक से या अगले टर्म से जैसे ही आप अनाउंस करेंगे नंबर ऑफ कैंडिडेट आपको सिलेक्शन करना पड़ेगा। जो मेरी
हम लोग को सॉर्ट आउट करना पड़ेगा।
आपको सिलेक्ट करना पड़ेगा कि किसको पॉइंट किसको दे इस बार मौका। तो ऐसे बहुत सारे लोग इस बार मैंने इंटरेक्शन में हमसे बात हुई कि तुम क्यों नहीं था, तुम क्यों नहीं था, हमको पता नहीं था, हमको क्या करना था, कैसे इस तरह की बात होती है। तो हमको लगता है कि ये बहुत अच्छा प्रोग्राम रहेगा। और टीचर वाले भी
करके रखना होगा फॉर प्रेजेंटेशन।
ज्यादा कैंडिडेट होंगे तो 2-2 बार कराइए।
हाँ सर।
ज्यादा
नायक साहब को नमस्कार सर।
नमस्कार सर। नमस्कार।
नमस्कार सर।
नमस्ते नमस्ते। नो, अगर ज्यादा आते हैं तो महीने में 2 बार कराइए।
हाँ सर, यही मेरा भी रिक्वेस्ट था डीके सिंह साहब से, पॉसिबल इसको कंटिन्यू किया जाए।
निशांत
सर।
डॉक्टर निशांत
सर
दीजिए इस बात पे जो बोल रहे हैं, एकदम ध्यान दीजिए इसको। अगर जरूरत पड़े तो 2 बार भी करवा सकते हैं फोर्टनाइटली।
दैट डिपेंड्स ऑन द कैंडिडेट। कितने कैंडिडेट आपके होते हैं?
बहुत मिल जाएंगे सर।
हाँ, बहुत मिल जाएंगे। हमको मेरा तो इस बार जो लोगों से बात हुई ना सर, बहुत सारे लोग तैयार थे, लेकिन वही जो फर्स्ट टाइम हेजिटेंसी होता है ना, कि कैसे कहाँ से किसको, इस तरह की फर्स्ट टाइम का प्रॉब्लम था, लेकिन हमको लगा कि होना चाहिए, अच्छा लगेगा।
जी जी जी।
हाँ सर, एक्चुअली ऐसे क्या होता है कि पीजी
में इंटरेक्शन,
टीचर्स जो है ना, टीचर्स जब
डर खत्म हो जाता है, एग्जाम का डर खत्म हो जाता है,
उसको मदद करेंगे शुरू में, उसको बनाने में, तो डेफिनेटली वो लोग आगे बढ़ेंगे ज्यादा से ज्यादा नंबर में। लेकिन टीचर्स को भी आगे आना पड़ेगा कि अपने बच्चों को प्रेरित करें और उसको मदद करें।
टीचर्स को पहले आना पड़ेगा।
हाँ, हेजिटेट करता है लोग जहाँ आने में, इसलिए सबसे पहला एक्शन ये हमें टीचर्स को चाहिए कि अपने स्टूडेंट्स को प्रेरित करे और उसको ये सब बनाने में मदद करे। कहाँ उसको दिक्कत हो रही है, कौन सा पॉइंट कैसे छूट रहा है, इम्पोर्टेंट कौन है, एडिटिंग करे। तब जो है सो लड़के लोग ज्यादा उनको इम्पेटस मिलेगा कि नहीं, आई शुड प्रेजेंट लाइक दिस। ये बहुत जरूरी।
बहुत अच्छा, थैंक यू सर। थैंक यू अशोक सर, थैंक यू सुखदेव सर। नमस्ते सर। तो ये बहुत अच्छा लगा कि ये कंटिन्यू होगा। निशांत, नीलम मैडम, शरद और नाग साहब।
डॉक्टर निशांत
सर।
मीटिंग कर रहा है
सर, आपकी आवाज नहीं आ रही है सर ठीक से।
भी आप प्लान कर लीजिए।
यस सर।
हम बोल रहे थे कि नेक्स्ट वाला भी एक प्लान कर लीजिए आप।
हाँ सर, हाँ सर।
स्टूडेंट, हाँ ये सेम प्रोग्राम।
हाँ, केस प्रेजेंटेशन है सर,
केस
कंटिन्यू रहेगा
वाला।
हाँ
सर, जल्दी से जल्दी एक बार फिर से रिपीट करवा दीजिए।
निशांत, हमारे डीएनबी का भी एक
और
स्लॉट रहेगा।
जरूरत पड़े तो मतलब इसको बीच में हम लोग रख सकते हैं 15 दिन पे, मतलब आफ्टर 2। और जो
आप
हम
लोग
लोग का
जैसा
CME
आदेश दीजिए
जैसे
सर।
चलते रहेगा वो चलेगा, और इसको बीच में भी हम लोग कभी अगर दो टीचर
रखिए,
हम लोग को अगर टीचर मिल जाते हैं तो हम लोग इसको कंटिन्यू कर दें,
टॉपिक
है
कवर्ड
ना।
होगा, ज्यादा
और
से ज्यादा
नॉर्मल जो हम लोग का
इन्वॉल्व होंगे,
एक मंथली होता है वो
अंग्रेजी पर
होते
रखने में कोई
रहेगा।
दिक्कत नहीं है।
स्टूडेंट वाला जो है केस प्रेजेंटेशन हम लोग बीच बीच में रख सकते हैं।
नहीं बढ़िया सर, एक चीज बस ये बताइए सर कि जो हम लोग का जो जैसे ये सृष्टि सुरभि देवर वेरी ब्रेव टू स्टार्ट ऑफ, जो हमारे एक्सटर्नल हैं उनके साथ भी माने कोऑर्डिनेट कर सकते हैं ना हम लोग इनका जो पावर पॉइंट है शुरुआत से ही।
हाँ हाँ हाँ
नहीं, एक्सटर्नल से नहीं करवाइए, आप
एग्जामिनर से नहीं करवाइए,
या किसी
एग्जामिनर से नहीं कराइए, किसी दूसरे से कराइए, एग्जामिनर से नहीं कराइए।
दूसरे से
ओके, जैसे इंटरनल से कराए ना।
हाँ, इंटरनल से कराइए।
इंटरनल नहीं, इंटरनल हमको जैसे एग्जामिनर रख रहे हैं, इंटरनल एग्जामिनर हमसे मत करवाइए, आप लोग कीजिए, हम लोग तो उस समय असेस करेंगे, तो ज्यादा नंबर ऑफ पर्सन का इन्वॉल्वमेंट होगा।
दोनों एक्सटर्नल ही थे आप, व्हाई योर फीलिंग कि आप इंटरनल एग्जामिनर
आपको बोला गया, अनाउंस किया गया है कि इंटरनल है ना,
छोड़िए ना, वो अनाउंस किया गया।
आप एक्सटर्नल थे सर, आज
आप एक्सटर्नल थे।
नहीं,
सुनिए ना, हमसे बात हुई थी उस दिन भी, हमको कहा गया था कि एक्सटर्नल में आप है, इसीलिए आप एक्सटर्नल थे।
बता रहे सर, अभी जो अनाउंस हुआ है ना, तो कहा गया कि इंटरनल है, इसलिए हमने सोचा कि ये एक्सटर्नल का
हमने केवल एग्जामिनर कहा, इंटरनल और एक्सटर्नल तो
कोई
कहा
बात नहीं है सर, उस बात के लिए हम आपसे क्षमा प्रार्थी हैं, उसको भूल जाइए, मानिए कि आप एक्सटर्नल थे। अगली बार से आप जब भी आएंगे,
ये हम लोग भी इम्प्रूव करेंगे सर। आप एक्सटर्नली थे, हो सकता है गलती से मुंह से निकल गया हो, ये हम लोग रिकॉर्डिंग देख लेंगे। हाँ नहीं, मैंने मंशा हमेशा से दोनों एक्सटर्नल की ही थी।
बात नहीं, क्वेश्चन पूछना था ना, उन्होंने बहुत अच्छा से क्वेश्चन पूछा है और हम उसको अप्रिशिएट करते, अदरवाइज हम अगर इंटरप्ट करते तो वो अच्छा नहीं लगता है।
अच्छा नहीं लगता है, कोई बात नहीं, हम तो इंटरप्ट करने वाले थे, लेकिन तब तक आप बोल दिए।
पर्पस क्वेश्चन पूछना है, जैसे भी क्वेश्चन आए।
मैंने माइक ऑन किया था, लेकिन
हमने सोचा जैसे कि हमारे यहाँ एग्जामिनर आते हैं, मैं इंटरनल रहता हूँ, तो मैं ज्यादा से ज्यादा मौका देता हूँ एक्सटर्नल को पूछने के लिए, बिकॉज इट हैज कम फॉर दैट। और हम चुप रहते हैं, और जब वो कहते हैं एक्सटर्नल कि अब आप ही पूछिए, तब हम पूछते हैं। ये कष्टी है, एग्जामिनर के लिए।
उस समय कैंडिडेट आपका अपना होता है, यहाँ कैंडिडेट बाहर का था, इसीलिए आप एक्सटर्नल थे।
नहीं सर, इंटरनल अगर हमको कहा गया तो कैंडिडेट मेरा हो गया।
अच्छा कोई बात नहीं, एक मिनट
कंफ्यूजन हो गया, चलिए ठीक है।
नहीं है सर।
तो नीलम मैडम, ये हम लोग को ध्यान देना होगा, है ना,
अगली बार से।
हाँ, ये इस तरह से कंफ्यूजन नहीं करना चाहिए हम लोग
नहीं पूछा, इसलिए हम नहीं पूछा, हम समझ रहे कि जो गरिमा है उसको मेंटेन करना चाहिए।
हाँ हाँ, एकदम सही बात है सर, कंटिन्यू होना चाहिए।
दिनेश सर, आप कुछ कह रहे थे सर, मेरे को आवाज सुनाई नहीं दी आपकी सर।
नहीं, यही हम बोल रहे थे कि अगर जरूरत पड़े तो 15 दिन पे भी इसको कर लेंगे हम लोग, केस प्रेजेंटेशन वाला। इसको हम लोग का जो नॉर्मल जो होता है ना मंथली, और अगर ज्यादा आता है, स्टूडेंट अगर आते हैं, तो हम लोग बीच बीच में कर लेंगे।
वही बात करें, पॉसिबिलिटी एक्सप्लोर कीजिए, अगर पॉसिबल है तो शुरू कर दीजिए।
दिनेश सर, लेकिन वो कैसे पता चलेगा, कैसे पता चलेगा? जैसे
शरद सर के पास
करवाएंगे तो फिर कैसे होगा?
आप डिफरेंट इंस्टीट्यूशन से, आप
अगर हम अपना डीएमडी से प्रेजेंट करवाना चाहते हैं तो फिर कैसे होगा वो, आप लोग
सर? शरद सर के पास पूरी लिस्ट है,
जिनका भी आएगा कि मेरे स्टूडेंट प्रेजेंट करना चाहते हैं, उनका